It's a Northwest lifestyle weekend on Como News. This is IRG's Health Talk. Back to Tom Hutler and Shannon O'Kelly.
Our first guest is Dr. Carrie Wilcox, board certified in sports medicine and family medicine from Orthopedic Physicians Associates, Compartment Syndrome. Now, Shannon, I've heard about this, and I've heard mostly about this, that it can be very dangerous and deadly.
Oh, it's a significant, serious condition and needs significant attention. You know, these are the things that you hear about a football player playing in a game and then waking up at 2 o'clock in the morning, their leg is swollen, and they go to the ER because they have a compartment syndrome. You got to watch this stuff.
All right, let's hear from Dr. Carrie Wilcox and Shannon O'Kelly talking about compartment syndrome on Como.
Dr. Wilcox, welcome to Health Talk. How you doing?
I'm great. How are you?
Well, I'm doing great. I'm glad you're joining us. We're going to talk about compartment syndromes and different things that can happen in these compartment syndromes. We just recently kind of heard about it in the news with Tyler Lockett sustained a lower extremity or a calf compartment syndrome. But before we get into that topic, tell our listeners about your practice. You're a family medicine physician with a sports medicine emphasis. What does that mean?
Well, so I was originally trained in family medicine, and off of family medicine, you can then specialize in sports medicine. So you have to go on for then fellowship training, where you basically are doing all musculoskeletal workups. You get trained in diagnostic ultrasound. We do a lot of therapeutic and diagnostic injections, treatments with tendinitis, joint disorders, multiple sort of disorders around the body that have to do with musculoskeletal.
And tell us about the practice you work in, the location, the type of practice it is, because you're surrounded by a lot of orthopedic surgeons, and you're the sports medicine specialist, so you must be really busy.
I am, and it's actually a great sort of location to be in, because orthopedic surgeons are kind of the guru of musculoskeletal medicine. They go in, they operate on people, they have to know the anatomy forward and backward. From my standpoint of being family medicine trained and then fellowship trained, we basically don't do any of the surgeries, but still have to know the anatomy and, looking at MRIs and x-rays. But then we also have sort of this added skill of diagnostic ultrasounds. So we are able to take some of their patients who may not be surgical candidates and actually do some testing on them with the ultrasound, trying injections, doing what we call needle tenotomy and PRP and different options that are not necessarily surgical, that then if they ultimately become surgical candidates, I know basically all of my partners, what they do, who I should be referring to, and then I get to follow up on my patients afterwards, so I don't lose them. That's
awesome. What a great collaborative environment to work with a surgical team and a specialist like yourself. Ultimately, the patient wins, right?
Yes.
And that's what it's all about.
They seem to really enjoy that combination.
Yeah. Okay, let's talk about our topic today, and you've probably seen this several times. There's a couple different things we want to talk about in the compartment syndrome world, and that's traumatic compartment syndrome and maybe this chronic or overuse compartment syndrome. So the stage is yours.
Yes, well, so compartment syndrome has this name that has basically often thrown around in terms of, especially coming from family medicine, where the understanding of it, what it means, who's presenting with it, it's a very easy term to say, I'm concerned about compartment syndrome. But what does that actually mean? Well, you can have the acute compartment syndrome that tends to happen with traumatic events, whether they're athletic, fractures, if you've been down and unconscious for a while, and just basically cutting off circulation. Generally speaking, I would say the most compartment syndromes that I will see will be traumatic events. So you'll have someone who has had some sort of injury, often more in the lower leg than anything else. So they can happen in the hand, the arm, the glute region. It's anywhere that really has compartments of muscular structure. And the issue with muscles is that they can move around. They're attached to bone, but they can actually slide around. And so the reason the body has compartments is to actually keep those muscles located where they should be located. But the separation between those muscles then are actually divided by a fibrous tissue called fascia. Mm-hmm. Fascia doesn't stretch.
Right.
So you're already setting up a situation that if there's increased pressures wherever fluid is coming, bleeding is coming, and increasing, there's no place for it to go. It goes in the tissues, and then the fascia fibrous band around it can't expand. So what ends up happening is the internal structures start to collapse. Mm-hmm. So that's really the dangerous part of compartment syndrome, and knowing whether or not you are concerned with compartment syndrome is really the most concerning aspect of the diagnosis.
So great job setting up the physiology and anatomy of that. So basically, in a nutshell, there's some kind of traumatic event in acute compartment syndrome, some kind of bleeding or fluid in these compartments, expanding, causing pressure, and that pressure cuts out blood flow.
Yes.
Back with Dr. Carrie Wilcox and Shannon O'Kelly right after this timeout on Como.
It's a Northwest Lifestyle Weekend on Como News. IRG's Health Talk continues.
We continue our conversation with Dr. Carrie Wilcox and Shannon O'Kelly on Como.
Dr. Wilcox, thank you again for joining us on Health Talk, and thank you for sharing your knowledge regarding compartment syndrome. It's a contusion, some kind of bleeding or fluid in this compartment. It causes increased pressure. That pressure is not good for blood flow, and that's the biggest issue, right?
Very true. And it's actually the venous system that becomes affected first. So as pressures increase, you have the venous system that starts to actually collapse. And the problem with the veins not being open anymore is the tissues then have no way to actually get rid of waste that they're trying to actually get rid of through the blood system. And then as you're having less return then to the heart to actually oxygenate more blood. And so the tissues start to get less and less nutrients, oxygen, and also with the vascular collapse, what ends up happening is a lot of the capillaries in the muscles then start to actually become more porous. They plasma starts leaking out, which increases the pressures in the tissues, which then a whole cycle starts to happen where then the vascular pressures become worse. They can't actually return any more blood. And ultimately what ends up happening is you have tissue necrosis. So muscle cells start to die. Then the arterial pressures start to drop because now you're actually starting to compress the abilities for the arteries to actually bring blood as well.
Not a good situation.
A very bad situation.
I mean, kind of an emergency situation. Yes. So an athlete, i.e., a football player like Tyler Lockett, that's why he stayed overnight. I mean, they're going to monitor that closely because if that doesn't get checked and that tissue starts to die, you don't rebuild dead muscle tissue.
Correct. And there's a time frame.
Right.
So generally, I mean, the concern with the lower leg is tibial fractures tend to be the largest concern for compartment syndrome. And 2 to 12% of all compartment syndrome comes from tibial fractures. And so having a patient who's already set up to have increased pressures starting within a compartment, if you actually do not get to the situation within 6 hours, we know statistically that your likelihood of tissue necrosis, muscle cell death, nerve issues, and compromise all start happening. And so, I mean, there's really a lot of research out on it based on timing. And if you hit that sort of 6 to 10 hour mark, the likelihood of tissues actually coming back from sort of their deterioration and what has happened becomes less and less. And if you hit that sort of 10 to 12 hour mark, it can literally be down to 8% of return of function.
Wow, yeah. It's a situation that needs to be monitored. And if there's intervention, you have to release those pressures. Tell us how you do that. That's a fasciotomy type thing, right?
It is, yes. And it's emergently done. And it tends to be, it's basically, if you think about it, you're almost like slicing open the area that has the pressures, increased pressures in it. So the fascia layers need to be opened. Thankfully, most of the time, the two compartments that tend to be affected the most are the anterior compartment and the lateral compartment of the lower leg. Those are easier to release. If you get into more deeper posterior compartments, those become more dangerous to release and less improvement can happen.
All good stuff. As we wrap up here, I want to thank you for your time. Also, we need to have you come back because there is another compartment syndrome. It's just overuse and you get a little bit of elevation and pressure. Sometimes runners get it. Can you come back and we can talk about that again?
I would love to come back.
Wonderful. Thank you so much for your time, Dr. Wilcox.
Thank you so much for having me.
That's been Dr. Carrie Wilcox, board certified in sports medicine and family medicine, talking about compartment syndrome. If you'd like more info, opaortho.com. And I guess the first thing to look for is to watch out for in something like this is the swelling overnight, the pain.
Yeah, absolutely. It's the swelling, the pain, the pressure, usually with a contusion. It's a traumatic event usually.
All right. Thanks to Dr. Wilcox. Jen Brown is coming up next on Como.